Welcome to PathoMad. Today I would like to discuss about papillary lesions of the breast. Papillary lesions of the breast can be classified as follows: intraductal papilloma, papillary ductal carcinoma in situ, encapsulated papillary carcinoma, solid papillary carcinoma, the same solid papillary carcinoma with reverse polarity, and invasive papillary carcinoma. All these papillary lesions, they show typical papillary architecture. Papillary means the finger-like projections. These finger-like projections are called papillae. All these lesions, 6 lesions, they show typical papillary architecture. Hence, all of them are grouped under papillary lesions of the breast. First, let us come to intraductal papilloma. Intraductal, as the name sounds, it arises within the lumen of duct. For example, this is the duct. Inside the lumen, it arises from within the lumen of the duct. Hence, intraductal papilloma. These are most common between 30 to 50 years of age. They can arise in the larger ducts and smaller ducts. When they arise in large ducts, they can be identified grossly as polypoidal intraductal mass. On cut section of this larger duct, within the lumen of the duct, you find this growth, polypoidal growth within the lumen. If at all they arise in smaller ducts, you cannot see grossly, but you can identify on microscopic examination. And these are most commonly associated with bloody discharge. They are associated with, and they can be palpable in subareolar region. On clinical examination of the breast, for example, left breast, this is the nipple areola. You can palpate under the nipple areolar region. You can palpate under the areolar region. It is palpable. It is soft and friable. Friable means upon pinching you feel as if it is breaking off. That is friable. And on cut section you can find this areas of hemorrhage. And most of them, 90%, are solitary. 90% of them are solitary. If at all they are multiple, they arise in smaller ducts. Multiple papillomas arise in smaller ducts which are peripherally located, and they are not associated with discharge, bloody discharge. See, this is the gross image of intraductal papilloma. This is the lumen. This is the lumen of the duct. This is the duct, lumen of duct. It seems as if it is arising from within the lumen, of the duct, intraductal papilloma. Microscopically, papillomas, they are complex and cellular, highly cellular, so highly complex, and they are intricately arborescent. Arborescence means it shows extensive branching. Like branches of a tree, they are extensively branched. Hence, they are called intricately arborescent. And the stroma is hyalinized. Hyalinization is a feature favoring benignity. It is of benign nature. And there are typically present, most importantly, two cell types. You can identify two cell types, epithelial and myoepithelium. See, this is the image of a normal duct. Within this duct is lined by, this is the epithelium, red color marking. Redly marked cells are the epithelial cells. This is the epithelial cell lining, and the blue color cells, these are the myoepithelial cell lining. So you can find this both in an intraductal papilloma. These are not distorted. And presence of myoepithelial component, they can be identified by IHC markers or immunostains like P63, calponin, smooth muscle, myosin, heavy chains. See, this is the microscopic image of an intraductal papilloma. On low power view, you can see this extensive branching, arborescent, showing this arborescent architecture of this papilloma. Extensive branching, these are extensively branching, shows extensive branching. And this branching, like branches of a tree. And on high power view, you can see this is the epithelial cell lining, darkly stained nuclei you can see. And these, underneath that is the myoepithelium. Myoepithelium, they are like pale. They have this pale eosinophilic cytoplasm. So almost it looks like vacuolated cells. These are the myoepithelial cells. These are the myoepithelial cells. These are the myoepithelial cells beneath the epithelium. Presence of epithelium myoepithelium is a characteristic feature of an intraductal papilloma. Coming to the second topic, papillary ductal carcinoma in situ. It is characterized by a single uniform population of atypical epithelial cells. So, see, mostly it contains single layer of epithelial cells. Single layer, uniform population of atypical because it's bad looking epithelial cells. And the cells are arranged perpendicular to delicate fibrovascular cores. For example, this is a fibrovascular core. All the cells are arranged perpendicular to the fibrovascular core. This is typical of papillary DCIS. And myoepithelial cell lining, they are absent along the fibrovascular cores. This is a fibrovascular core. You cannot find any myoepithelial cell here. Only epithelial component is there. So this is again a fibrovascular core. You cannot find any myoepithelial cell lining here. Only epithelial component can be seen. So myoepithelial cell lining is typically absent along the fibrovascular cores. But the myoepithelial cell lining are present at the periphery of the spaces involved by papillary DCIS. This is the in situ nature of this particular lesion. For example, away from this is the fibrovascular core. This area does not have any fibrovascular core. You can find this myoepithelial cell, here myoepithelium cell. At the periphery of the spaces, you find this myoepithelium cells. So the myoepithelium cell lining present at the periphery, but not along the fibrovascular core. And the helpful clue to the diagnosis of papillary DCIS is presence of other patterns of DCIS like cribriform or solid patterns. And there is absence of apocrine metaplasia. Apocrine metaplasia is nothing but increased eosinophilia, increased pinkishness of the cells that is absent in papillary proliferation. In this extensively proliferating papillary cells, papillary epithelial cells, the apocrine metaplasia is absent. There is no increased pinkishness. And the diagnostic trap is presence of globoid cells. Globoid cells, they mimic myoepithelial cells because they are like look-alike of the myoepithelium cells. They too have this large pale eosinophilic cytoplasm, and hence they can be mistaken for myoepithelium cells. In this image, see, these are the globoid cells. They almost look alike like myoepithelium because they too have this pale eosinophilic cytoplasm. They are lookalikes of myoepithelium cells, but these are globoid cells. But the immunostain for myoepithelium cells, it helps in the diagnosis. This is the hyper view of this papillary DCIS. Here you can see the fibrovascular core and absence of any myoepithelium cells around or along this fibrovascular core. Coming to the third topic, this is encapsulated papillary carcinoma. As the name suggests, it is well circumscribed, surrounded by a thick fibrous capsule. See, low power view, you can see the thick fibrous capsule. Most common in older women and their central location. And bloody discharge, it may be present or it may not be present. Microscopically, they appear to arise from within a cyst or a duct, like in situ location or intracystic lesion, duct. It appears to be from a duct or a cyst. It appears as if it is arising from within. And fibrovascular cores are very delicate and are surmounted by, like taken upon by, monotonous proliferation of atypical cells. The cells are rapidly proliferating, and all these atypical cells, they occupy or they encroach upon the fibrovascular cores. Hence, they cannot be easily visualized. They are very delicate fibrovascular cores. Along with this papillary pattern, you can also see solid and cribriform patterns as well. Myoepithelial cell lining is absent along both fibrovascular core and also the periphery. So there's complete absence of myoepithelium cells along the fibrovascular core and also at the periphery. Both ways, myoepithelial cell lining is absent. Whereas in papillary DCIS, myoepithelial cell lining is absent along the fibrovascular core, but you can find it at the periphery. But here in encapsulated papillary carcinoma. So both at the both the places along the fibrovascular core and also the periphery, both places the myoepithelium cell lining is absent. And rarely, because since we are naming it as a carcinoma, rarely we can see metastasis, axillary lymph node metastasis. It's extremely rare, but it is possible. And how do you stage and manage? Because we are calling it as a carcinoma, but still the WHO working group, it recommends to stage and manage this tumor as an in situ lesion. As an in situ lesion, you are managing this. If at all you find this any micro-invasiveness or invasive carcinoma, they can be reported according to the size of largest focus, according to the large tumor size on largest lesion you take, and you stage and report according to that particular largest focus of conventional invasive carcinoma. This is recommended by the WHO working group. Hyperview, here you can see the capsule. Encapsulated papillary shows papillary pattern, papillary architecture, and there is absence of myoepithelium. Here is a solid papillary carcinoma. This is most common in the older women. Microscopically, the tumor is composed of, as the name said, is solid, multiple solid nest of neoplastic epithelial cells. See, it is highly cellular, highly solid pattern, solid, like cells are tightly packed, and it is nest in each group, one group, one group, highly nested pattern. Uh, Inside the nest, fine fibrovascular cores give papillary architecture to the tumor. On low power, you see only the solid nested pattern. Where is the papillary pattern? On zooming in, the fibrovascular cores, they give this papillary architecture. They give this papillary architecture to the tumor. Tumor cells they can be spindled. They can be spindled, and they have the streaming pattern, streaming, all going in one direction. All the cells going in one direction. Like this, they can have the streaming pattern. They are going in one direction. And it can be associated with mucin production as well. The cells can produce mucin in most of the cases. And myoepithelial cells, they are typically, because it is a carcinoma, they are absent within these nodules and also at the periphery. But in some cases, they are absent in the periphery. And how do you stage and manage? According to this WHO working group, tumors, there are three categories. You categorize into three types. First, tumors with round nest and complete or partial myoepithelial layer. There are round nests are there. Myoepithelium lining, they can be present completely or they can be partially present. Then you take it as DCIS, ductal carcinoma in situ. You consider it as an in situ lesion with solid papillary pattern. If the tumor with nests of irregular borders, tumor is of irregular borders, and there's a jigsaw growth pattern, haphazard growth pattern of the neoplasm, and myoepithelium layer is absent, then it is of invasive nature. If at all you are in a dilemma, tumor, if only few of the nest are lacking myoepithelium, these are the nest. Okay, few of the nest, they lack myoepithelium. Few of the other nest have this myoepithelium. Then you're uncertain about the invasion. Then you stage and manage it in situ only. If you're uncertain, consider it as in situ. Coming to the fifth variety, solid papillary carcinoma with reverse polarity. Reverse polarity. Polarity means in a normal, like normal epithelium, the cell is resting on a surface. The nucleus, they tend to be basally located towards the surface on which it rests. This is a normal polarity. The cells are organized, like they have this pattern of arrangement. This is a normal. In cases of reverse polarity, the nuclei tend to be away from the surface on which it rests. That means they are apically located. They are apically located. This is the reversal of polarity. And the cells are haphazardly arranged. They're scattered everywhere. I mean, they do not follow a particular direction. And it is a very recently described entity. Solid papillary nests are there, like solid papillary carcinoma. These are also arranged in nest of bland columnar epithelial cells. Nuclear apically located. That is called reverse polarity. And the tumor cell nests infiltrate through the breast parenchyma and fat in a haphazard pattern. Haphazard. They do not follow a certain pattern. They are haphazard, scattered everywhere. And obviously, the myoepithelial cell layer is absent. So, here you can find the nest. Solid nests are there. But on hyper view, see, this is the some resting surface, and the nuclei apically located away from, there's a distance from the surface, apically located. This is called reverse polarity. Solid papillary carcinoma with a reverse polarity. Last and finally, we have invasive papillary carcinoma. This is the rarest of the rare, very rare entity. We do not usually report it. And if at all you find this papillary, invasive papillary architecture, first you have to exclude metastasis, any metastasis from the ovary or lungs before you give the report to be a primary papillary carcinoma. Not much reported cases about this. Yes, thank you all.